Good afternoon, everyone. Welcome to the latest session in CADTH's COVID-19 webinar series. I'm Suzanne McGurn, President and Chief Executive Officer at CADTH. As we start off today's session, I'd like to begin by acknowledging that I'm speaking to you today from Ottawa, Ontario, which is the traditional unceded territory of the Algonquin and Anishinaabe people. I thank all of the generations of people who have taken care of this land and encourage everyone participating today, anywhere in Canada and internationally, to think about the land where you are and the people who have been stewards of that land. Today's topic, how COVID-19 is changing the evidence landscape, is both timely and relevant, perhaps even more so today on World Evidence-Based Healthcare Day. For those of you who have not heard of this day before, this is the first annual of what I hope will become a very important day to recognize and celebrate the impact of researchers, academics, students, clinicians, consumers, patients, and other agents of change who are driving improvements in quality and outcomes of healthcare globally through evidence. I'd just like to add that today's topic certainly resonated with me when it was proposed. I've recently moved from being an evidence user as a senior policy and decision maker within the Ontario Public Service to leading this organization that produces evidence to help senior healthcare decision makers across governments and health systems make informed decisions about health technology. My transition was happening just as the world was grappling with the rapid spread of a dangerous new virus. It raised many questions about evidence now and into the future. In early March, when the World Health Organization declared the pandemic, very little was known about the virus. Yet the need for decisive action was immediately clear, and the demand for timely evidence was and remains intense. It also brought into sharp focus the important dialogue about evidence, quality, timeliness, and certainty, or more often what we've been dealing with, uncertainty. As the needs and expectation of evidence users have accelerated, health technology organizations and health research bodies have had to reconsider their priorities and processes to ensure that their work is relevant, responsible, and responsive in the face of this new crisis. Today, we have three speakers with us who will take us inside the changing evidence paradigm, how this has affected evidence users and producers alike, what this could mean in the long run in terms of how and what type of evidence is used to support health decision-making. You're going to hear from today Dr. Chris McCabe, Executive Director and CEO of the Institute of Health Economics, Anne Hayes, Director of Research Analysis and Evaluation Branch within the Ministry of Health in Ontario and co-chair of the Evidence Synthesis Network, and Dr. Nicole Mittman, CADTH's Chief Scientist and Vice President of Evidence Standards. Each speaker is going to take time to share their insights about how COVID-19 is changing the evidence landscape from their perspective, after which we'll move into a question and answer session. You are able to submit your questions at any time by clicking on the Q&A tab in the Zoom control bar. Please let me know if you want me to direct your question to a specific speaker or to everyone generally. Additionally, if you have any technical issues, use the Q&A tab to let us know, and CADTH's event team will try and resolve them for you. Without further ado, and to maximize our time for these great speakers, I'd like to introduce Dr. McCabe, and let me call on Dr. McCabe to get things started. Take it away, Chris.
Thanks a lot, Suzanne, and thanks to CADTH for inviting me. Preparing this talk has really been quite humbling. I think this is an incredibly good news story. Next slide. So the background, I think we all know, but it's really quite shocking when you see the numbers in black and white. So our first case in Canada was on the 25th of January, and obviously was a traveller coming into Canada. By the 18th of March, so less than 2 months later, there were more community transmission cases than travellers coming in. By the end of March, all Canadian provinces had enacted emergency powers to enable them to address the challenge. The first wave peaked on the 3rd of May, if we measure it by daily cases, where just that day we had 1,799 cases, 175 additional deaths. And the total deaths at the 3rd of May was over 3,500. That led to an unprecedented demand for immediate evidence. Next slide, please. And the evidentiary needs were across the spectrum, and I'm going to group them in terms of policy making, clinicians' needs, and public's needs. And so the policymakers in government and in health systems wanted to understand the epidemiology of this disease. What were contacts, exposures, how they varied by setting, what was the infection rates by different, for the whole population, subgroups, and again, how it varied by settings. And what were the outcomes? What were the risk factors for hospitalization, death, long COVID? This virus only jumped to humans in December of last year. And there we were in March with policymakers saying, what do we know? They also wanted to know about the effectiveness of management strategies. They quite rightly took to themselves really remarkable emergency powers to limit our everyday activities as citizens of Canada. And they wanted to be confident as far as possible that what they were doing would work so that they could justify it to the citizenry. What activity restrictions, what was the effectiveness of them? What was the effectiveness of keeping schools closed and the risk associated with different reopening strategies? How about testing strategies? Which targeted testing strategies or population level testing strategies? I try not to be offended that no one asked about cost effectiveness as a health economist, but actually there was a lovely paper out in JAMA last week or the week before showing how the value, the economic burden of COVID ran into trillions. The question, were these interventions, if they worked, going to be cost effective? Or it was so simple to answer in the affirmative that it wasn't really worth making a priority for researchers. Next slide, please. Clinical practice was interested in clinical management, risk factors that could inform their triage. How do they manage the patients in the emergency department, on COVID wards, in ICUs? They also wanted to know about the safety and effectiveness of therapeutics. We had, political leaders in different countries making very strong statements about the effectiveness of different treatments. And that was in the absence of evidence to a large degree at that time. We also obviously wanted to know about the safety and effectiveness of vaccines as they become available. Next slide, please. The public was really interested in their risks. They wanted to understand the risks to themselves and the risks to others, the risks to their loved ones. So what was their risk of being infected? How much of a risk might they pose to their loved ones of infecting them? What was the risk of hospitalization if they did get affected? What was the risk of death? And again, very interested in knowing how that changed by different groups in society. We were all, I think, in the early days, very, very concerned about our children and what their infection risk was and what their likely outcomes were. We were very concerned about whether they would actually spread the disease to their parents and their grandparents especially. And so there was a lot of interest in the public and they were reaching out, asking these questions over social media as well as conventional media. And as we and governments asked the public to accept restraints on their freedoms, they wanted to know, does it work? How effective is distancing? How effective is the lockdown? Masks. I mean, what we thought originally and now what we're confident about now has changed radically. And we are going to have a conversation about vaccines with the public. They want to know before they agree to be vaccinated how well these things are going to work. And they want to know about the risk, the safety of these treatments. Next slide. So here in Alberta, And I think, similar activities were going on across all provinces, and organisations like CADTH were, doing them pan-Canadianly. The Alberta Health Services created a scientific advisory group for COVID-19. They have produced 39 rapid reviews between the beginning of April and the end of September. So that's averaging one every 4.7 days. These are levels of productivity that are just unimaginable before COVID. The government wanted to have information about what the future might look like, and so we created a COVID-19 model, which enabled them to look at the effectiveness of different interventions, vaccines, and distancing, and masks, and those sorts of things, and would could forecast the epidemiology of how we expected the cases and clinical outcomes at the population level, and also look at the effectiveness, the value of vaccines at different levels of coverage in the population, because we know the vaccines are not going to be available in a volume that allows us to treat everyone. Sort of from day one. It's going to take time to have enough vaccines to treat everyone. So the impact of different levels of population coverage were an important part of the discussion. And this is what we were doing in Alberta. I'm sure similar things were going on in other provinces to try and help decision makers, even when the evidence was highly uncertain. Next slide, please. I think one of the things that really struck me very early on was the creation of social media networks amongst clinicians to rapidly share learning. And this is a paper from earlier this month about the role of social media in sharing trusted content between clinical teams in different countries. I remember very early on having the privilege of sitting in on a teleconference between emergency docs in Italy and the emergency docs here in Alberta, so they could learn, get the learnings from Italy and bring it into their clinical practice. And that sort of global collaboration between clinical communities has been key in developing the quality of the care and the confidence in care that people who are infected with COVID get when they turn up at a hospital these days. That, I think, it's been incredibly important and powerful. Next slide, please. What we've also had is an unprecedented explosion in research. So this is a screenshot from the MEDEX IV preprint server. And you can see the number there, 9,691 articles on COVID that have been lodged. That's a massive amount of information. And as it says there in the warning, these should not be regarded as conclusive, guide clinical practice, behavior, or be reported in news media as established information. And yet, let's be honest, they were. And some of the things that we have concerns about actually made it into the peer-reviewed journals, leading peer-reviewed journals. So there was a huge amount of effort that went into producing evidence, but there was huge heterogeneity in the quality of that evidence. And in many ways, I think it represented actually a potential source of harm. And so next slide, please. What was the fantastic response to that? And it was the creation of global evidence synthesis networks. So this is the one in Canada, COVID-End, to synthesize the available evidence that was being produced, sort out the chaff, identify the quality, and be able to provide reliable evidence to clinicians on what worked and what didn't. It's a massive endeavor, necessarily time limited, but such an impressive contribution to the quality of care and the evidence-based nature of care going forward. Next slide, please. Lovely article in Science I recommend you go and read to understand just how big a challenge that was. Next slide, please. We've also had the creation of massively delivered large-scale innovative trials. So we've had the UK recovery trial that showed us that DEXA works, and we've had the Solidarity trial from the World Health Organization, which gave us some confidence that remdesivir probably doesn't, and neither do the other two candidate therapeutics. So incredibly important. This is, less than 12 months after the virus jumped to humans, we've had conclusive trials on a global scale. Just outstanding and frankly unthinkable before this time of pandemic. Next slide. And again, please. The other thing that I think is most remarkable is the vaccine trials. We have had public sharing of the protocols. So the transparency in research, the standard of transparency and the expectation of transparency in research, I think has taken a step forward, which is unlikely to be reversed. We will have better idea of what's being done in the research earlier as a result of these steps by these companies. And I think they deserve applause for that. Next slide, please. And in the public, their evidence providers and experts have been reaching out to the public and making their knowledge available. So here's CAMH here in Canada. Next slide, please. And this independent SAGE, so the Scientific Advisory Group for Emergencies in the UK, is a public body that there was concern about the robustness of their advice to government. And so this independent group was established of experts. They stream their meetings and the public are allowed to send them questions directly over social media. Unparalleled provision of evidence and expertise to the public. And again, I don't think we'll be able to walk back this level of engagement. Next slide. And this work, it's not all quantitative. Trish Greenhalgh has had a massive impact, but here a really simple visual to enable people to identify the risk associated with different levels of activities. It was designed for the public to use and to guide their behaviors. It's not a funnel plot. It's not our sort of outputs. It's stuff that's useful for the public. And again, setting a standard for us going forward that we're not going to be able to walk back from. Next slide. So my take-home message is, okay, the intensity of the work is probably not generalizable and sustainable in the long time. But the lesson that if we want to go fast, go alone, but if you want to go far, we go together, I think is something that will stay with us. Thank you.
Thank you, Chris. And a great note to end your introductory comments on. Really, really thoughtful and provocative. Our next speaker is Anne Hayes. I have the pleasure of having worked with Anne previously, and in fact, our old offices, we probably would have had to have a discussion about social distancing in our workplaces. So it gives me great pleasure to introduce Anne. So over to you.
Thank you, Suzanne. Thank you for having me today. So today I'm going to speak to you about how COVID-19 has transformed the work of the Research Analysis and Evaluation branch of the Ontario Ministry of Health. COVID-19 has given us an opportunity to pursue the integrated knowledge translation approach that we've been developing over recent years, to really drive the closer relationship between the evidence world and the policy world. On slide 2, please. So the research branch at the ministry has had a mandate to provide evidence services to clients for decades. Specifically, our mandate has included funding strategic health research, leading integrated knowledge translation initiatives, providing expert evidence synthesis, evaluation, and economic analysis services for internal ministry clients, and leading evidence-related policy and planning. Our work has been impacted by COVID-19 in a number of ways. Most importantly, We've had to keep up with the accelerated pace of evidence generation that Chris referred to, and the speed in which requesters want that evidence synthesized for their use. In response, we've pursued a collective impact approach with our partners as a way of being both efficient and effective in meeting the needs of our clients. And I'm going to tell you a bit more about that later. Our clients are making decisions on many issues where the scientific evidence is not yet available or conclusive. So expert advice and jurisdictional scan evidence has become a bigger feature of our work than ever before. Our clients are busier than ever and don't have time to read lengthy, dense evidence products. So we've adjusted how we package our products, moving more definitively to the use of plain language summaries, more charts and graphs, and more summarized content. Our clients used to be primarily within the Ministry of Health, but with COVID-19, our audience has expanded to include clients from across the health sector. We've seen firsthand the hunger for curated evidence products among service providers and others involved in frontline care. There's also been a significant investment in research at both the federal and provincial levels that needs to be translated into policy quickly. As a result, we have developed an approach to bringing translated evidence to ministry knowledge users in a way that directly speaks to their needs. You can move to the next slide, please. So now I'd like to give you a few practical examples of how we've responded to these impacts. So first, we established the Evidence Synthesis Network. Early on in the pandemic, we looked around and realized that other evidence synthesis shops were facing the same pressures as we were, that we were all working on the same issues and we had complementary strengths. In Ontario, we have some of the best evidence synthesis shops in the country, if not the world. So we reached out and suggested we work together to improve our efficiency and our collective impact. As a result, we've now got a network that includes national and international powerhouses, including CADTH, McMaster Health Forum, and COVID-19, which Chris mentioned, SPORE Evidence Alliance, Ontario Health, and others that work with us to respond to requests from across the health system. We receive a request from within the ministry or from anyone in the health sector. We crowdsource it to the network and then bundle responsive materials and products into an evidence synthesis briefing note. These evidence synthesis briefing notes can be found on the Evidence Synthesis Network website, courtesy of the University of Toronto. The network is also working collaboratively with our new Science Advisory Table and the Modeling Consensus Table, both involved in directly advising COVID-19 command table and other COVID advisory tables. And we are the principal source of evidence synthesis for these tables now. You can go to the next slide. We've really broken new ground by creating new evidence products to be responsive to client needs. The evidence synthesis briefing notes include a plain language summary along with more detailed charts and summaries of scientific evidence and jurisdictional scan information. Less free text, more accessible content. The RABE Evidence Update, which is shown on this slide, is a weekly product that provides a snapshot of the most recent evidence synthesis briefing notes and other forms of rapid response, along with curated articles and a summary of trusted sources. Traditionally, we work on a request basis and would only have provided the resulting products back to the requesters. The evidence update arose from our realization early on that we could share the results of the requested products to a wider audience and more people could benefit. So this product now goes out widely across the health sector, and we've had many emails from readers who tell us how beneficial it has been to them and how they distribute it further to within their networks. It's really fulfilling a gap in curated evidence products across the health sector. Reaching such a broad audience has been one of the most gratifying parts of our work. We just produced the 30th edition of this product. You can go to the next slide. The Challenge Questions Initiative is our newest initiative. Recently launched, it's designed to accelerate the translation of research results into evidence that can be taken up by ministry knowledge users. Early on in the pandemic, we started defining research priorities. Through multiple rounds of consultation with ministry knowledge users and COVID advisory tables, this work evolved to become more defined challenge questions, reflecting those issues the ministry really needs answers to. Associated with the launch of the new COVID-19 Ontario Health Data Platform, we're now asking the research community to respond with an expression of interest to answer a challenge question. Once an EOI is received, the researcher is connected with ministry knowledge users to clarify the researcher's approach in hopes of increasing the chances that the results can be taken up by the ministry. If this new program works as planned, it will significantly change our expectations of knowledge translation, really shifting from traditional passive approaches to a more focused and dynamic relationship between researchers and ministry knowledge users. You can go to the next slide. Finally, I'd like to mention our research funding initiatives. We sought to extend the impact of provincial and federal research funding to benefit Ontario's pandemic response. We've partnered with CIHR on a COVID-19 mental health and addictions funding call, and with the Ontario Ministry of Colleges and Universities on a general COVID-19 research call. Our funding is dedicated to projects that are high priority to ministry knowledge users. So could you go back to slide 2? You can read all about all these initiatives at our, there we go, at our refreshed website. So as a result of all the content we were generating through COVID, we decided to refresh our website. So just last week, we launched the refreshed website, which you can go to, and you can find the evidence updates and all of the other things that I've been mentioning. Finally, I'd like to finish off by highlighting that none of this work would have been possible without the many valued partners. COVID-19 has allowed us to bust silos, push boundaries, and take risks in ways that is allowing us to have greater impact in our work than ever before. While the pandemic has been a huge challenge for all of us in so many ways, it's actually been a good thing for advancing the evidence to policy space. Thank you.
Thank you, Anne. I really appreciate that presentation and your comments about curated evidence. New word for me is just music to my ears as a knowledge user. Having it presented in a way that I don't need a translator is just so exciting. Our last speaker, Nicole, I think she's going to try and bring the conversation together and put it in the context of both things that are happening here within Canada and on the international stage. So over to you, Nicole.
Thanks very much, Suzanne. And thank you both to Chris and to Anne for highlighting some of the real issues that they've learned from moving evidence into policy. I thought I would start with a top 10 lessons learned list. Please forgive me, that top 10 list turned into 16. So why don't we go to the next slide? So this is the usual way, and Anne highlighted this sort of passive approach. There's some sort of publication in a peer-reviewed journal, which then takes time, and sometimes whether it's a hurdle like a brick wall to go into some sort of policy decision making. Next slide, please. What we've seen now is instead of father time, we see a stopwatch, and now the dynamic expression of how research goes back to policy decision makers and vice versa. The questions are going back and forth to researchers. So this seamless integration, or almost seamless integration, of trying to get evidence into practice has now really shown how important the work that folks do who build evidence. Next slide, please. So let's start with our top 16 lessons learned. We've seen the pace of research has changed. What used to take 3 months, perhaps, for a rapid response is now being requested in 3 hours. Having been sitting at the evidence synthesis table in Ontario, understanding how quick and how important any kind of evidence would be to help make a decision at either a bedside or policy decision-making table is important. And so we need information soon, and sooner rather than later. That is happening around the COVID space, and that the old pace of potential research in terms of peer review, where a submission goes to a journal, the idea of a review period, which is an important critical review period, and then a publication can take months to a year, versus now the burgeoning need for immediate, intermediate results to be published in some sort of preprint format, as Chris highlighted. And that we're now taking evidence that used to be saved or reserved for final results are now being actually published in an interim fashion. Well, as we can see last week with respect to the Solidarity trial being published as interim results in a preprint format. So the pace has changed. There's very high public engagement into this work. I think, for the public to talk about models, exponential curves, understanding mortality benefits, understanding even the difference between incidence and prevalence, and no more shall the epidemiologist have to explain to their parents again what they actually do for a living. So, how do we communicate with the public? We just heard about the different way that to translate information into a decision maker that is tenable and understandable. And there really is pressure on researchers and policy decision makers for change and to understand the relevance. So looking at what does the evidence mean and how do we interpret its use? And that Chris highlighted some of the, why didn't we look at cost effectiveness? I think finances will be important. We've heard that the financial strain around the COVID pandemic will shine a light on perhaps looking at things differently and how we fund things. So for example, underfunded public health organizations, or perhaps maybe we need to think about priority setting, and decisions about healthcare and technologies will need to consider those kinds of initiatives. Next slide, please. So I think evidence matters more than ever. Certainly, looking at the types of evidence, the quality of the evidence, the types of different study designs, filling gaps, trying to meet in the middle between a randomized controlled trial and an observational study. And even if we don't have that level of evidence, what do we do? But we do need to start to and critically imagine that what do we need to do with this evidence and how will it help inform policy? Priority setting, as previously already mentioned, the demand for new technologies will exceed often the ability to do the work. And sitting at that evidence synthesis table, the amount of questions, and at our own COVID CADTH task force table, the number of questions that we received, how do we choose, how do we prioritize, and providing parameters around those comments and questions. And then value, what is the value we're assigning? Typically from a health technology assessment, we talk about either cost effectiveness or value. And are we talking now long-term versus short-term value? And how do we do this? Well, we have to think about different thresholds or different parameters or different attributes around the decision-making itself. Next slide, please. So, and as mentioned, collaboration is key, international, national, provincial, different interjurisdictional, and also researchers have been collaborating with one another, as Chris mentioned. So on a global front, whether it's COVID or whether it's COVID end from a Canadian perspective, but also researchers who have never collaborated before or even worked in the same space are actually starting to form groups of networks. So, listening to folks who are thinking about aerosolized particles, that doesn't only include the antimicrobial folks, but also includes the physicists, the occupational hygienists, and all kinds of different works and specialties. And initiatives such as, for example, the Best Brains Exchange, which was a collaboration between CIHR and PHAC and CADTH to bring in experts from across the country with different expertise to highlight an issue around particles in the air. And then also our own CADTH initiative on HVAC, where we brought in experts from different, whether they're occupational health or physicists or heating and ventilation specialists, to understand some of the key issues around evidence. There are new ways of making decisions. We're all in a virtual format here. How do we deliberate? How do we make decisions? How do we inform our decision making? And then also thinking about, are there additional ways we need to think about decisions and additional kinds of considerations? So now thinking about public health, vaccines, different time frames, different thresholds. Clinical interventions need HTA. So we typically live in a world of drugs and devices, but we're starting to see about, again, for example, the HVAC example or the particle example, or actually having a clinical intervention as part of this work as well. Next slide, please. So, but there is competition still. We saw with the emergence of the granting or funding agencies that have focused particularly on COVID, that left other researchers out of the environment and not able to get their funding. So putting a halt on some of that. So going forward, we'll need to think a little bit around how to balance some of this work. And academic groups who are all doing perhaps evidence synthesis, we're all vying for the same pot of money. And so it's despite the amount of collaboration, there's also competition. We've talked about new ways of communicating, whether it's a newsletter, whether it's a model, whether it's a different format in terms of peer review and preprint. How can we use our existing systems? And one of the things that Chris indicated is what can we learn going forward with respect to communicating evidence? And that there are new, different perspectives, the standard thinking about drugs, and we've talked about maybe we also need to think and incorporate some of the hospital or the public health agency perspectives as well. Next slide, please. So this is the almost second last slide. Considerations of real world data. If we are going to be going forward with immature or intermediate data, we'll need to think about continued evidence generation. And so how do we do that? And is this an opportunity for real world evidence? And ethics, all of these decisions we make are about recommendations on allocation and our ethical issues around we're choosing one kind of technology over another, and what are the ethical issues around that. And we've all heard about the health and human resources with respect to the burden of treating COVID and managing it, but we'll also need to think about training the next generation with new skills. And the final slide, please, is humility. I think Chris started out with it's been humbling, but I think science by itself it's by its nature is self-improving and evolves. What we knew before, we don't know now. What we know now, we didn't know in the past. And so now the way we work together, the way we think about data, the way we critically evaluate data, and the way we use data, I think as a field, science it has a little bit of humility on how we appreciate the value of evidence and also appreciate the value of public health. And with that, thank you.
Thank you, Nicole. And there's been no shortage of activity sending in questions. So we have about 15 minutes or so. If there are other questions, please feel free to add them. What I'm going to try and do is actually, to the best of my ability, group some questions that have come in together and go to each of you just to ask about your comments on them. So the first one's actually pertain to masks and mask wearing, but it is about sort of what learnings are there with 2020 hindsight. The example was the lack of published studies on masks as a good reason to advise against the use of masks in early days. Masks are still not recommended by some experts due to the lack of the studies, for example, in the Netherlands or Sweden. It is a classic problem of argument from ignorance. A proposition is false because it has not yet been proven to be true. One perspective on it. Another question related, the evidence on mask wearing is a good example of how evidence and information change over time. And the messaging that the public has received was inconsistent, confusing, and changing. It's led to the public not knowing what to do or feeling lack of trust from decision makers, resulting in inconsistent behavior. Aerosols versus droplet is another example. What should we think about that? And, what are our lessons learned as we look back on the last few months? So maybe I'll start with you, Chris, and then go to Anne and Nicole on this group of questions.
Thanks, Suzanne. Great question. Great group of questions. So it is a classic. We'll be using this as a teaching example for many years to come, where absence as evidence was treated as evidence of absence. And I think the recommendations partly reflected the evidence that was available, but also a concern that the supply of masks should not be overwhelmed such that healthcare systems couldn't get it. There was a real desire to protect that supply in the early days, because the PPE for health workers was obviously paramount. So there was concern not to trigger a demand for healthcare level PPE in the general population. That said, I think as the evidence developed that actually there was a prima facie case that there could be benefit, we were a bit slow to pivot and say, well, the risk of harm is low, and therefore, let's say move to a positive recommendation, but a positive recommendation with research. It was possible and still is possible to do research on this. Good epidemiological research taking advantage of the differences in the timings of adoption of masks, such as we saw in Ontario, means that we can have good research to look at the evidence. Ideally, we could have cluster randomized controlled trials. It's about the reversibility consideration, and there's nothing particularly irreversible about the recommendation to use masks. And I think that wasn't thought about carefully enough. We could have said, let's use masks whilst we do the research, because it's pretty easily to reverse, but it's hard to get people to trust if it looks like the messaging is inconsistent. So I think we made a mistake of being overly cautious. We made a mistake in our communication, and we made a mistake not to recognize the need for good research in that space. And as I say, I think it'll be a teaching example for many years to come.
Thanks, Chris. Anne, any observations on the topic? Again, it doesn't have to be specific to masks, but the things that have changed.
Yeah, I actually love these questions because masks in particular, the aerosol versus droplet, and I would add to this particular list testing generally, and all the kind of different debates on testing. And I think I would like to make 3 points about this. First of all, I think we have to realize that decision makers have to make decisions regardless of whether the evidence is perfect. And that really is a kind of guiding principle for a lot of the work that we do in the research branch. We can't afford to be too purist, because we know that our clients are going to make a decision regardless. So we want to do our best to support that in the best way we can. In the case of these particular examples, I think we've learned a lot through COVID about, the types of evidence. And a lot of what we try to focus on is being very explicit with what is the type of evidence that we're bringing you, and how rigorous is it, and what are the limitations. In the case of masks in particular, we just did an evidence synthesis briefing note on the effectiveness of masks in community settings. When the team gave me the note, I was like, what? Are you kidding me? There's actually no scientific evidence that masks are effective. But there are observational studies, there's a lot of modeling which shows, and there are lab studies. So there's enough evidence to bear out what also I think intuitively we see is true. The other thing, especially with aerosol and droplet, And the Best Brains Exchange that CIHR did on transmission really highlighted this. A lot of your understanding and interpretation of the evidence depends on the disciplinary orientation that you bring. And so, you know, this aerosol versus droplet is a really good example of where, you know, I've been in rooms where people have doggedly argued, you know, a particular perspective based on their decades of disciplinary, you know, loyalty that, you know, are not necessarily helpful, are not really helping us to advance. So I think we have to really check our own biases and preconceived ideas when we're trying to consider the evidence. But I go back to where I started. People got to make decisions about this stuff anyway. And so we really need to do our best to help them, to guide them, and to give them the best we can, even if it's not perfect.
Thanks, Anne, very much. And Nicole, there's still a lot of questions to go. Anything you'd like to add to this one?
No, I just think maybe just the three things would be the pace, because questions were coming in so fast, and the need for the evidence was so immediate, that, you know, some of our communication early on might not have been perfect, although that could have evolved over time. And then the last part was really around, we are used to looking at the traditional type of evidence, and what Anne and Chris have highlighted is that some of the non-traditional ways of looking at evidence have become much more, or bubbled up to the top for us to start to look at as well.
Thanks. I'm going to ask this question just quickly, just looking for one example from each of you. Can any of the speakers recommend an alternative to the traditional peer review research that might be quicker, but still provide a comfortable mechanism for quality control? And I think I'm going to start with you, Nicole, because I think that's what you were actually getting at with the end of your last response.
Yeah, and I think that there is a need for some sort of a hybrid approach to looking at peer-reviewed articles, going through the process of having, you know, critical appraisal with reviewers' commentary, but doing that in a shortened time frame to maintain the integrity of the scientific process, and also some of the transparency around it as well. So I don't have a solution, but I think that that's on every journal's mindset, with respect to all the editors and reviewers, about how we can do better along the way.
Chris, any magical solution in the offing?
There's no magic. I think I'm really excited by the potential of the living systematic reviews. So they took it's a substantial upfront investment to get that, you know, the body of literature evaluated and synthesized. But then if a living systematic review can deal with the flow, and because the team has that deep expertise and they have that structure, actually, I think they can update the evidence much more rapidly. And so instead of waiting for a paper to be published in the peer-reviewed journal, these papers being submitted to the living systematic reviews, then we drop that time out and go straight to how does this add to the evidence? And all of the things that we do for a systematic review are applied to that flow of papers, and the actual totality of evidence can get updated much more rapidly. So I would like to see living systematic reviews essentially become the journals for their specific areas of content areas of the future. I think, you know, that's the future we need for the speed that we need.
Anne, anything you'd like to add to this? Oh, you're on mute.
I'm just going to be quick on this. I think, like, peer review is still probably the best thing that we have, but I think maybe there's ways that we could improve the processes, right? And you know, the word agility has become a big part of what we talk about, and so I think in everything we're doing, we're having to, you know, maybe sometimes it feels like we're shortcutting process, but we're really just making it more streamlined. And so maybe there's ways that we can speed up some of what these traditional processes have been and do it faster, but still do it and maintain the integrity.
Thanks for that, Anne. I'm actually going to just chime in with a comment because I don't know that others would have noticed this, but Anne, I do think one of the things that you've talked about, and I actually think is a foundation of HTA, is actually having evidence tables and debating the evidence, which is something quite different than what we're used to. So I do think that that brings a different kind of rigor and debate to the dialogue. So it's something I do hope to be able to see more of. All of you have talked about the speed and having to make choices about, what is a priority. And there's a great question that has been asked about engaging with patients and talking to patient communities. They've used a specific example regarding the hydroxychloroquine, which was an important drug for many patients. And it was only by talking to patients that the problem started to be identified. But more generally, I guess I would want to ask each of you, how do we keep the patients well engaged and make sure that we're not missing a critical piece of why it is that we're doing things, which is actually to make sure we have better patient care. So I'm going to start with you on this one, Anne, if that's okay.
Yeah, I mean, I have to admit, in the early part of COVID, a lot of people were acknowledging that patients were left off. Like all of a sudden, when the pace got frantic, I think people kind of defaulted to really kind of some bad habits of just getting it done without consulting. So I think only in the more, the latter part, like when we were able to sort of recover a bit in the summer and then regroup, I think now, the patient voices are coming back into the processes. I know for us in the ministry, we now have a chair of our Patient Family Advisory Council who we can go to, and there's a process of populating that council again. And we also have the ICES public engagement, citizen engagement panel. And so I think we're now sort of getting back to that, but I have to admit, I don't think we've done a very good job, especially in the beginning. But obviously it is still critical to getting those patient voices.
Thanks, Anne. Nicole?
I think I wholeheartedly agree that including patients and or public members on these evidence tables would highlight things like risk tolerance or appetite for some of the challenging new therapies that are out there. Also help us understand what kinds of outcomes matter to patients in general, whether it's a specific patient-reported outcome tool or measure or an experience that they've encountered, and then also helping us understand what the best ways to communicate with the patients and the public groups would be.
Thanks. And Chris, anything for you on the patient perspective?
Yeah, I think it was really tough because we normally think about the relevant patients that we pull on being those who are affected by the disease. And we were trying to get moving to limit the size of that patient group. They weren't organized. And this particular question actually talks about the patients who were bearing the opportunity cost of a decision. So, this is one of my hobby horses. How do we get access to the patients who bear the opportunity cost of decisions? So those whose access to hydroxychloroquine was going to be impacted if it was widely used for treating COVID. And I think that's a challenge we still haven't figured out how to do. I think good representation, public representation is a good sort of midpoint, but we need to do better. And I think also clinicians need to remember that they have an advocacy responsibility for their patients. The clinicians should have been flagging up to us all that if you start supporting widespread use of hydroxychloroquine, my patients may have access problems. And some did that, in fairness, but I think it's also fair to say that we were slow to be aware of that issue.
I've got two more questions and we're really tight for time. So again, just quick responses. A person formerly with CADTH who is actually asking a great question on this particular day and at this particular moment in time. How is the evidence community responding to what is often seen as attacks on science and evidence emanating from political figures or through social media on decisions such as canceling Halloween, making the really tough decisions? I think we've all seen it. And I guess, we've got a room, hopefully a room full of people on Evidence Day. I think it's important for us to think about that from a resiliency of the work that we do. So I'm going to go to you first this time, Nicole. Any thoughts on how is the evidence community responding to the criticism?
I think we need to go back to the idea that we really need to look at the data and not play politics with the evidence, and that the looking at the quality or integrity of the data helps inform some of these policy decisions, and not letting pressure play politics with that particular data.
Thanks. Anne, want to chime in with anything?
I would just say at the same time, I think we need to applaud leaders when they take difficult steps based on evidence. I mean, I've been fortunate to have a front row seat to some of the decisions where, the leadership has listened to the science, and they have then, turned around and taken action. And that's really gratifying to see that they're listening to the scientists and then being willing to take some of the difficult action. So I think at the same time, that we get frustrated, but we also need to acknowledge when, good decisions are being made, even if they're not popular.
Thanks, Anne. And Chris.
Thanks, Brian. Yes, I think it's important that we stand by the evidence and we act as non-partisan advocates for the evidence. And I think, Dr. Anthony Fauci in the US is a great example of doing that. It's hard for us often, if it's a government that we have a close relationship with as an organization, for us to be public in our statements of what the evidence says. But I think we have to have the courage to do that, to say our role is to be critical friends. And this is what the evidence says. And then the decision makers can legitimately say, I've weighed that evidence, and for the following reasons, I've come to these decisions. And I think it's an important responsibility for us as the evidence advocates to publicly say that when necessary.
Great. We have exactly 3 minutes left. So with that, I'm going to ask each of you for a final comment based on the discussion or the presentation. So I'm going to do it in the same order in which you presented. So over to you, Chris, to start off with your closing statement.
I think the evidence community has a lot to be proud of in Canada and globally. We will continue to do better. The most important thing is that we don't let the lessons of how to be better lapse. We must move forward with the being better based on what we've learned.
Thanks, Chris. Anne?
I agree. I'm going to go back to my sort of closing statement about silo busting, boundaries being broken, taking risks. I think for me, that's been a very energizing part of this. And I think we need to not fall back into complacency and doing things the way that we've always done them. I think we need to ride this wave further. There's a lot more that we can do to shake up how we do our evidence work. And I'm very hopeful and energized by the possibilities, and look forward to working with many of you on that.
Thanks, Anne. Nicole?
And I might add that I would like us to continue how to communicate evidence, the good, the bad, and the ugly evidence, and to ensure that people are understanding the work that we do.
Thanks. There's a great question. I'm actually going to use it for my closing. There's a question that says, thanks for the great webinar. As a PhD candidate about to enter the world of evidence, this is both exciting and terrifying. That's how I feel taking on responsibility of working at CADTH. So I echo those sentiments. I hope you've learned lots of things in this session to make you excited about the career that you've taken. I just want to thank everyone, our three speakers, to everyone who's tuned in, and for every single one of you who are on this call who participate in or contribute to evidence on this first annual World Evidence Day. Thank you for everything you do. You make a difference. Sometimes it's hard to see, but the work you do from this day forward will never be thought of the same. So thank you all for tuning in, and look forward to more webinars and seeing you at future events. Thanks, everyone.